to AETCM, the Emergency Medicine channel. Today let us discuss about hepatic encephalopathy and some of the major causes for jaundice in pregnancy. Liver is a major detoxifying organ in our body. When the liver is damaged, the detoxification, we take a lot of food materials which may contain a lot of toxins, will not be detoxified. If the liver is damaged, these toxins which taken through the diet will not be detoxified. So all these toxins can bypass liver and go to the central circulation and central nervous system, and it can produce a lot of problems in the nervous system and can produce hepatic encephalopathy and other damages to our CNS system. Hepatic encephalopathy is a complex neuropsychiatric syndrome characterized by disturbances in the consciousness, behavior, personality changes, and fluctuating neurological signs and flapping tremors. So, patient clinically can have altered behavior and flapping tremors, but the neurological system may be completely deranged, and it can be picked up by even EEG. But normally we don't prefer to do an EEG in hepatic encephalopathy. It's a clinical diagnosis. So EEG changes can be there, triphasic wave encephalopathy can be there, but routinely we don't do any EEG in patient who is having hepatic encephalopathy. Again, it is classified into acute and chronic liver disease induced hepatic encephalopathy. So hepatic encephalopathy can be seen in acute liver injuries like paracetamol poisoning, pregnancy-induced liver injuries, or drug-induced liver injuries, viral hepatitis-induced liver injuries. All these things can produce acute liver disease and acute liver failure, and it can lead to hepatic encephalopathy. Again, chronic liver diseases like alcoholic liver disease or chronic hepatitis can also have liver disease, and acute on chronic can produce acute hepatic failure features. Now, if you see the pregnancy induced liver problems, there are multiple problems can occur in pregnancy. First trimester, normally we get viral hepatitis like hepatitis B, hepatitis C and hepatitis C. We have to especially talk about hepatitis E, because hepatitis E is a fecal-oral route of transmission. It is very benign in a normal person, but in pregnant ladies it can produce severe problems including hepatic encephalopathy, acute and fulminant hepatic failure. All these problems are very common in pregnant ladies. Hepatitis E induced problems are very common in pregnancy. Drug-induced hepatitis can be there in pregnancy. It can be due to paracetamol, it can be due to anticonvulsant drugs, it can be due to tetracycline-induced problem. All these things can occur. Again, rarely methyl topa, that is a drug used for high BP in pregnancy, hypertension in pregnancy. So that itself can produce sometimes hepatitis. Third trimester, again infections, septicemia, biliary tract obstruction can also produce jaundice. Hepatitis E, we already discussed, that also can come into picture in third trimester. These are the most important causes in first and second trimesters. Again, other causes like intrahepatic cholestatis of pregnancy can also produce problem in third trimester of pregnancy. HELP syndrome is another important problem, that is hemolysis, elevated liver enzymes can also produce jaundice in pregnancy. Acute fatty liver of pregnancy is a rare but serious liver disease without known etiology. It can be related to preeclampsia, eclampsia or HELP syndrome. So here also you can have high levels of SGOT, SGPT. It is due to an inherited fetal mitochondrial fatty acid beta oxidation defect, and mortality is nearly 10% in patient who is having acute fatty liver of pregnancy. But most of these patients recover with delivery, like syndromes like eclampsia, preeclampsia, HELP syndrome, acute fatty liver of pregnancy. All the major treatment is delivery. So once the patient is delivered, you can see that patient improves in 1 or 2 days. Intrahepatic cholestatis of pregnancy, it frequently develops in late pregnancy, third trimester of pregnancy, and who are genetically predisposed. The most common pregnancy related liver disease is intrahepatic cholestasis of the pregnancy. It can present with generalized itching, pruritus, mainly in the hands and feet, with other skin manifestation due to jaundice. The outcomes are good. After delivery, there will not be any clinical finding even in intrahepatic cholestasis of pregnancy. You can see here the different causes for pregnancy induced jaundice. Jaundice seen to pregnancy state, intrahepatic cholestasis we have already seen, severe preeclampsia syndrome, eclampsia, HELP syndrome, acute fatty liver of pregnancy, severe hyperemesis gravidarum, disseminated intravascular coagulation. Jaundice unrelated to pregnancy, they are hepatitis A to E. In that, E is very, very important because E is a benign condition in a normal person, but in pregnancy it can become troublesome. Gallstone, obstructive jaundice, drug induced. Any drugs can produce hepatitis both in pregnant lady and a normal person. Hemolytic jaundice can also produce can be produced by various infections like malaria, leptospirosis, dengue fever in our country. Jaundice when pregnancy is superimposed on a chronic liver disease, that is also possible. Cirrhosis, tumors of liver, all these things you can get acute hepatitis. And now we can see the pathology of hepatic encephalopathy, because whatever may be the reason for hepatitis, whether it is hepatitis primarily in a normal person or hepatitis in a pregnant lady, if the liver is completely failed, patient develops hepatic encephalopathy because all these toxins which was detoxified in the liver now bypasses liver and go to the central nervous system, and it can produce hepatic encephalopathy. It is mainly due to shunting of portal venous blood to systemic circulation. All these toxic materials crosses the liver and it reaches the central nervous system. The toxic materials are ammonia, that is a major toxic material. One word about ammonia investigation. When we suspect hepatic encephalopathy, we can see that ammonia is elevated, but the levels of ammonia will never correlate with the severity of hepatic encephalopathy. So that is very, very important. Only you can tell it is hepatic encephalopathy by doing the test, but you cannot tell because if it is very high, suppose ammonia levels are very high, we cannot predict that patient is having severe encephalopathy. So that is a problem with ammonia. Mercaptans, short chain fatty acids, phenol, false neuronal transmitters like octapamine, inhibiting neurotransmitter like GABA. These are the materials which crosses the liver circulation and reaches the central circulation and produces hepatic encephalopathy. And there are some precipitating factors, especially in chronic liver disease. They are applicable even in acute liver disease. In that mainly is gastrointestinal bleeding that increases protein and ammonia in the intestine, and ammonia production will be more. Excessive dietary proteins like animal protein intake. Renal failure can produce azotemia and increase protein in the blood. Constipation, again same mechanism, increased protein absorption from the intestine. Electrolyte imbalance, hypokalemia is very, very important because many of these patients are on diuretic classics that can produce hypokalemia. So hypokalemia is one of the major trigger for hepatic encephalopathy. Hypovolemia, hypoxemia, alkalosis, again electrolyte imbalance, hypokalemia is one of the major cause for alkalosis. Drugs like narcotics, other sedatives, hypnotics, all can produce trigger hepatic encephalopathy. So somebody is having liver disease and If these factors are present, it can trigger hepatic encephalopathy. Now, hepatic encephalopathy stages, easy classification is stage 1, 2, 3, 4. Stage 1 is inversion of sleep pattern. Daytime patient will be sleeping, nighttime patient will be awake. Second stage onwards, patient can develop flapping tremors. So, flapping tremors is, once you see flapping tremor, it is grade 2 or more with mild confusion. Grade 3, gross disorientation. Grade 4, coma. So, these are the grades for hepatic encephalopathy. Grading is very important for following up of this patient, because first day if you are seeing the patient, if the patient is having only in grade 1, second day if the patient develops flapping tremors, that means deterioration of the patient. So, that is very important. So, underlying diseases can also we can classify type A, type B and type C. Hepatic encephalopathy occurring in a setting of acute liver failure is type A. Type B is hepatic encephalopathy occurring in the setting of a portal systemic bypass with no intrinsic hepatocellular disease. Type C, hepatic encephalopathy occurring in a setting of cirrhosis with portal hypertension or systemic shunting. So, already pre-existing liver disease is there, shunting is there, then that is type C. That most of these patients coming in type C, but in pregnancy most of the time it is in type A. Now, when the patient come to emergency room, we have to evaluate the patient. You have to look for any GI bleeding. You have to put a Rayleigh tube and see any blood in the stomach. If it is there, we have to aspirate. Otherwise, that will become a focus for ammonia production. Infections are very important. We can see the complete blood count or urine routine, chest X-ray to rule out infection. Procalcitonin can be done. Hypokalemia should be ruled out. Renal failure, creatinine, urea can be done. Hypovolemia, again urea is a good marker of hypovolemia. Hypernatremia is good marker of hypovolemia. Ultrasound with IVC diameter is a good marker of hypovolemia. All these things can be done in emergency room. Urine output, that is also good marker of hypovolemia. Hypoxemia, sedative and other hypnotics history should be taken. Hypoglycemia, routine GRBS should be done in patient who is having liver disease, and continuous monitoring of sugar is also important. Constipation should be ruled out. If there is constipation, definitely we have to give laxatives that we will discuss about afterwards. So, we do routine blood count, blood sugars, blood counts, electrolytes, ammonia. Ammonia we already discussed. It level will not correlate with the severity. Urea, creatinine, ABG evaluation. Look for any flaps in the patients. Flapping tremors are very important. Infection screen should be done. Ultrasound abdomen should be done to see what is the size of the spleen, what is the size of liver, portal hypertension is present or not, whether fluid accumulation is there or not. All these things are important. Now, most important treatment in hepatic encephalopathy is prevention of hepatic encephalopathy in a patient who is having chronic liver disease or acute liver failure. So, prevention is most important in patient who is having chronic liver disease or acute liver injury. So, lactose is a osmotic laxative. It can reduce the pH, it can reduce the ammonia producing bacteria in the intestine, it can remove stool from the stomach. Syrup lactose 30 to 60 ml every hour until diarrhea occurs. That is a treatment. Lactose can be given as enema also, retention enema 300 to 700 ml can be given as lactose retention enema. Now, gut sterilization is the next strategy. In that, we are removing all the bacteria which can produce ammonia in the gut. We can give rifaximin, that is one of the drug. Rifaximin is a non-absorbable antibiotic which mainly act against the gram-negative organism. We can even give this drug in traveler's diarrhea because it's a non-absorbable drug. Here the dose is 400 mg 3 times daily or 550 mg twice daily. Metronidazole and neomycin are all alternative drugs. We can give IV antibiotics in a patient who is having spontaneous bacterial peritonitis. IV ceftriaxone 1 gram IV BD can be given, or 1 to 2 gram IV OD also can be given depending on the severity of infection. Potassium correction is very, very important because many of these patients who is having chronic liver disease may be on Lasix or furosemide that can remove potassium. That is started to remove the water, to reduce the body fluids. Edema can be reduced with Lasix, but we have to understand that this drug can remove potassium from our body. Hypokalemia is one of the trigger for hepatic encephalopathy. So in that case, we have to give potassium. If the potassium is low, we have to correct the potassium with IV potassium, and we have to start spironolactone to prevent potassium loss through the kidneys. So we can give furosemide with the spironolactones. Furosemide will act as a major diuretic. Spironolactone is a diuretic, and it is a potassium sparing anti-aldosterone diuretic. So that can be added to Lasix. Now, flumazenil is a benzodiazepine antagonist. Flumazenil can be given in hepatic encephalopathy if the patient is severely drowsy. 0.2 mg IV over 15 seconds, then 0.2 mg every minute as needed, up to 1 milligram total. So this can be given in patient who is having drowsiness. So this is a benzodiazepine receptor antagonist. Many of these patients can have raised ICP and altered behavior, can be treated with mannitol, can add 3% saline or mechanical ventilation and hyperventilation. All these things are possible, but most of these patients recover without any major neurological complication in hepatic encephalopathy if treated properly initially itself. Diet is very important. These patients can deteriorate on high protein diet, so we have to give a low protein, high carbohydrate diet. Continuous glucose infusion may be required in many patients. Electrolyte imbalance should be corrected because many of these patients can have hyponatremia lab wise, but mostly that is a dilutional hyponatremia. So when we see hyponatremia in this patient, we should never give extra salt. That will add on the fluid. It will retain more salt and more water. So we should understand that this hyponatremia is mostly due to dilution. It's a dilutional hyponatremia, so that can be left like that. But we have to correct the potassium. Potassium is one of the most important electrolyte imbalances in hepatic encephalopathy that can trigger hepatic encephalopathy. Sedations, we should be very careful when we are using sedatives because liver is already damaged. Many of these sedatives can aggravate the problem, but unfortunately sometimes we'll have to sedate the patient because they will be agitated. We can use midazolam. It's a short acting drug. Flumazenil can be given if we want to revert the problems of benzodiazepine, or we can go for alternative drugs like fentanyl or propofol. All these things are available. So but remember, as far as possible, we should try to avoid sedatives and hypnotics because the clearance of these drugs will take longer time if the liver injury is there. So we have discussed about one of the few common causes for jaundice in pregnancy. Most of these causes which can produce jaundice in pregnancy that reverts with termination of pregnancy or delivery. After delivery, most of these patients improve, but conditions like hepatitis E that may be very dangerous in pregnancy. And we have also discussed about one of the some of the common treatment options of hepatic encephalopathy or hepatic encephalopathy preventive measures in emergency room that can even continued in emergency ICU also. So we have discussed about hepatic encephalopathy and hepatic encephalopathy preventive measures and some of the common causes which can produce jaundice in pregnancy. Thank you.